Hi, everybody. I think we're live right now. I'm not sure if people can hear or see me. Okay, so you've got me. Okay. So welcome to our webinar training here at Boston Child Study Center, Los Angeles. I am Lynn Ann Ching. I'm a co-director here at BCSC in Los Angeles. And today we're going to be doing a introduction to dialectical behavioral therapy webinar. It's part of our Learning Lunch webinar series that we've been presenting. So today will be a 2-hour training. I'm going to be presenting to what I assume are a group of you who do not have any prior training or experience with dialectical behavior therapy, with DBT. And primarily this training will be geared towards clinicians or practitioners or mental health care workers in the field. And I'll be presenting as if you have no prior experience with DBT. So I'm going to go to my slides. I'll be sharing my screen so that you can all see. So hopefully you should all be able to see the slides currently. Okay. You might be. Yep. Okay, great. Hopefully everybody can see this. So this is Introduction to Dialectical Behavioral Therapy. And we're going to be doing sort of an overview of the treatment, some of the principles and theories that inform the treatment, as well as some of the protocols and interventions that are involved in the therapy. And then the second half will be focused on DBT skills training, which is a big component of DBT. So the first question is, what is dialectical behavior therapy? Essentially, in the 90s, Dr. Marsha Linehan, who's out of the University of Washington in Seattle, created this treatment because she was finding that the traditional cognitive behavioral therapy that she was using with her patients, with a certain population of her patients, was not being effective. She was seeing a lot of treatment dropout, a lot of inpatient hospitalizations, and not a lot of success or movement with traditional cognitive behavioral therapy. And so she created this treatment, which is essentially at its core a cognitive behavioral treatment. So DBT is a cognitive behavioral treatment. I like to think of it as DBT is CBT plus this component of sort of mindfulness and acceptance. And the basis of the therapy is this idea of dialectics or dialectical, which I will explain as we move forward. So dialectics, essentially, I'll give a brief definition of it, is the idea that there is no absolute truth, that there can be multiple truths as opposed to just one. And I'll go into this a little bit in more detail on the next slide. But the overall idea in DBT is that we are balancing these two concepts of acceptance and change. So the change component really is this cognitive behavioral therapy piece. You know, in CBT, for those of you who are familiar with that type of treatment, CBT focuses very much on, you know, identifying thoughts and changing what is labeled sometimes as thinking errors or dysfunctional thinking patterns, which will in turn, you know, change behaviors and change emotional experiences. And so this focus on change is part of the reason that Marsha Linehan was experiencing, I believe, difficulty in using a very change-oriented treatment with a population of clients and patients who were very sensitive to invalidation.
Looks like it's stuck on this. Maybe try minimizing it because I think it went away. There's also a lag.
Let me see. I'm not sure if any of you are seeing this second slide. The top says, what is dialectical behavioral therapy? I'm going to stop sharing my screen for a second and then reshare it to see whether we can get this to work. Sorry about that if some of you couldn't see that screen. Let's try this again. Okay, hopefully you can all see the slide that says what is dialectical behavioral therapy right now. There might be a little bit of a lag.
Don't go full screen, I think.
Oh, don't go full screen? Okay. Is that working better?
Mm-hmm.
Okay. I'm going to keep it out of full screen so that hopefully we won't have that same issue. This focus on this very change-oriented focus in traditional CBT was what Linehan was finding was not effective for this population of patients, in particular borderline personality disorder, which was what the original treatment was designed to treat. We're going to talk a little bit about that more later. And some of the expansions and adaptations, that the treatment has expanded to treat more than just borderline personality disorder. So these concepts of dialectics, balancing acceptance and change is the overarching thing that we are trying to do in this treatment. So the CBT components emphasizing that change, and then this component of acceptance, mindfulness, radical acceptance, validation. These are all concepts that embody the acceptance side of the treatment, and we'll talk a bit more about that. One thing to note, DBT is both a principle-driven as well as a protocol-driven treatment. In other words, what guides us is these theories of dialectics, this concept of dialectics, as well as biosocial theory, which we're going to talk about. And as well as the principles that drive the treatment, there are also these particular protocols that clinicians are asked to use when implementing DBT. So to try to keep that in mind, that it's a balance of both protocol and principle. So let's talk a bit more about the idea of dialectics. As I said before, the overall concept of dialectics is that there is no absolute truth in the way that we think about things. So, we talk about this idea of black or white. It's either black or right or white. We work with a lot of teens in our practice here and children, and we talk about this idea of, do you hate your parents or do you love your parents? Could one actually do both? Could one both love and hate their parents at certain times? Or if you get an argument with somebody, you have a fight with a friend, can you be both angry at some of the things that happened during that fight and also sorry or apologetic for some of the things that you did? So the idea of dialectics is to be able to balance multiple truths that sometimes maybe even seem contradictory, right? So some of my kids might say, no, I'm just really, really angry. I'm not sorry about the things that I said in that fight. I'm just mad. They were wrong. That's a very non-dialectical approach of just getting polarized into sort of one truth. And so in dialectical thinking and in DBT, the goal is actually to be able to find some synthesis. And synthesis does not mean compromise. So we sometimes talk about, finding the gray, in black and white. I like to think of it more as the synthesis is not a compromise between different truths or different perspectives. It's more of a new truth that you might come to. So, black could be true, white could be true. Maybe the synthesis is green. It's sort of a new color or a new truth that you might come to. So, what does it mean to both be angry at your friend that you got into a fight with and sorry at the same time? Where does that leave you? What is the synthesis between those two kind of maybe multiple truths that exist? This idea of a Zen koan or a Zen koan, I think koan is the correct pronunciation of it, as I was corrected by one of my students once when I was talking about this. So a Zen koan is a story or a parable or a question that is often told to students of Zen And the goal of it is to help them to arrive at sort of a kind of intuitive or wise mind knowing. Um, and this idea sort of embodies this idea of finding synthesis in this concept of dialectics. And so one of the koans, or one of these sort of dialectical dilemmas we present, is this question: can you stand in the same river twice? So I have this little image here of this fisherman standing in the river. And some people might say, well, yes, you can. Of course you can. I could go to the Mississippi River and I could stand in it today, and then I could go tomorrow and I could stand in the Mississippi River again. So the answer is yes. Yes, you can stand in the same river twice. And somebody else might say, no, it's not the same river. If you go to the Mississippi River today, there's a certain current, there's a certain flow, or there's the rocks are here, or the dirt is in this way, or the wind is blowing in this certain fashion. And if I go tomorrow, that's not the same river. That's a different river. And so this is a little bit of one of these dialectical dilemmas, right? So what is the answer to that question? Can you stand in the same river twice? The answer is yes and no. That's sort of the answer. And if you had to come to some sort of synthesis or some sort of knowing of the answer to that question, what would that be? So this might seem a little lofty, but this is sort of the best illustration I can think of in terms of how to explain this concept of dialectics. And so if we're working with people that have been diagnosed with borderline personality disorder, which we'll talk about more what that means, or just individuals who have extreme emotions, can get caught in polarized ways of thinking or feeling or behaving. Those of us who work with teens or adolescents, this is sort of developmentally appropriate maybe. You can imagine now how this concept of dialectics, which weaves into the treatment, begins to become relevant. So our goal in DBT, helping clients think, act, approach life in a more dialectical fashion, getting unstuck, moving away from polarized ways of thinking, feeling, and behaving into more balanced or synthesized ways. So that's kind of a principle that's woven through the treatment. And so if we go back to this other slide, I hope you can see this as I went back, that overall balancing between acceptance and change, right? You might think, oh, acceptance and change, those are two totally different things. How can you do both at the same time? And so this is kind of that idea that in this therapy, the way we're approaching clients is with this, on the one hand, validating and accepting their current experience, as well as using some of these interventions we have for bringing about behavioral and cognitive change. Actually, I'm gonna go to this slide so we could talk a little bit about borderline personality disorder before we move back to dialectical dilemmas. So again, as I said, DBT was created initially for treatment of borderline personality disorder. Obviously, it's been adapted to other populations, other diagnoses, but this is sort of the original intent of the treatment. So I like to review this just to sort of give a little context of how this treatment was developed, and then talk about sort of the applications. So, we have here the DSM-5 criteria for borderline personality disorder, 5 or more of the following. Some of you may or may not have seen this before. I'm not going to go through each one of them, but what I want you to see is how Linehan has actually reorganized these DSM-5 criteria into, I hope you can see this slide, reorganized into a DBT lens. Has that changed over? Are you on the slide that says DSM-5 BPD symptoms reorganized through a DBT lens? Okay. So you can see here, she's taken those symptoms of BPD as they're listed in the DSM-5 and restructured them along these 5 sort of poles of dysregulation. And the way that Linehan really conceptualizes borderline personality disorder is it's really a sort of dysregulation of these 5 areas, right? So it's a disorder of emotional dysregulation, which if you can imagine you're emotionally dysregulated, it leads to interpersonal dysregulation, behavioral dysregulation, cognitive dysregulation, and then self-regulation or dysfunction. So you can see how she's taken these DSM-5 symptoms and reorganized them along this through this lens, through these 5 poles of dysregulation. It's just an interesting way to think about it. She also poses this theoretical idea that people who struggle with borderline personality disorder often struggle with these 3 main dialectical dilemmas. And you can see some of the things in the dysregulation poles sort of captured here in the dialectical dilemmas. So she talks about a person with BPD struggling between emotional vulnerability versus self-invalidation. So on the one hand, emotional vulnerability is feeling very emotionally sort of exposed. We talk about feeling sort of like an emotional burn victim. You know, you wear your heart out on your sleeve. We're going to talk about the biosocial theory. So some of those biological components of emotional sensitivity being shown here, versus all the way on the other side, self-invalidation is this idea of telling yourself that, you know, you shouldn't be feeling this way, invalidating your emotional experience, maybe not being in touch with your emotional experience at all. The second dialectical dilemma, active passivity versus apparent competence. The idea of active passivity is one who actively is in a state of trying to seek that the environment act on their behalf. It looks a little bit like a sort of learned helplessness, where one will try to, in a passive way, get the environment to act on their behalf because they are truly feeling like they don't have the skill level or they're feeling helpless. So, you know, oh no, I'm not capable of doing that. You know, you call and cancel my doctor's appointment, or you know, I can't get out of bed today. I'm not capable of, you know, doing anything. Somebody else kind of do this for me. But it's getting the environment to act in such a way that's not direct. It's not a direct sort of assertive, effective way of getting the environment to act or to help. There's a passivity to the way in which the individual tries to activate the environment. So that's on one end of the spectrum. And on the other hand, we have apparent competence. So this is the individual, and it's the same individual, right? So they could have both of these components to them, and it can look very confusing to the outsider to say, oh, well, you were so actively passive and sort of helpless in this one situation, and now on this other side, your apparent competence. You know, it looks like the ability to, you know, to be very competent, and sometimes it's actual competence. You know, a person who can function very well, get to work or get to school, or be very competent and functional in some areas of their lives. And it can often be mistaken, you know, sometimes people will label that kind of thing manipulative. You know, how come you were so able to get to work or get to school yesterday, and now today you're so helpless and trying to get me to do things for you? And the recipient of this kind of behavior can often become, you know, it can be judgmental. They can feel manipulated. You know, DBT, we try to avoid these sort of pejorative terms like naming individuals as being manipulative. But you can imagine how to the environment, someone who swings very quickly between these 2 poles or these 2 sides of these dialectical dilemmas, you know, it can be confusing. The last dialectical dilemma is this idea of unrelenting crisis versus inhibited grieving. Unrelenting crisis is maybe that stereotypical, you know, quote unquote, the borderline patient, which has been very stigmatized, I think, in you know, in the mental health community. One who's, you know, revolving door in and out of hospitalizations, a lot of self-harm, a lot of suicidal behaviors, this unrelenting state of crisis on the one hand, versus inhibited grieving, the other side, where emotions are, you know, hidden, tamped down, maybe in the case of PTSD, you know, it's this numbness, the inability to express those emotions or grieving or strong emotions that might be occurring. And again, this could happen in the same individual. You might see somebody in unrelenting crisis for a period of time, and then they swing to this other side of inhibited grieving. And so again, the goal of DBT, bringing the individual to more of a synthesis, more of a balance between these two extremes. I realized that I hadn't reviewed biosocial theory. I think I'm missing a slide. Oh, here it is. So let me review biosocial theory, and this might help put the dialectical dilemmas in a little bit more context. So Marshall Linehan has a theory about what leads individuals to experience difficulties like emotional dysregulation, or like some of those symptoms that we saw relevant to borderline personality disorder. So she sees it as these two components of biology and the social environment. So she says, there are some individuals that are just born more sensitive. And we define emotional sensitivity with these three characteristics. High sensitivity means, some stimulation, some trigger or something that might cause a certain level of emotional response from a non-emotionally sensitive individual. In an emotionally sensitive individual, it would create a greater experience, right? So anxiety, for example, a trigger to one person, which they might not experience at all, to the emotionally sensitive individual will feel that anxiety very, very deeply, right? Or intensely. So high sensitivity means that deep, intense experience of an emotion. High reactivity refers to, and I often use this metaphor of a sports car, of a supercharged sports car, going from 0 to 60 in 0.5 seconds. So the sports car's gas pedal is extremely sensitive. You tap it lightly, it's going to rev, the engine's going to rev really high, and then it will go from 0 to 60 very quickly. So that high reactivity of emotional levels. And then a slow return to baseline. So this individual who's sensitive will take longer than typical to come back down to their baseline. So it's going to take that Ferrari longer to come back down to the speed limit than, say, the Toyota. And I teach this theory to, we present this theory actually to clients, to families, and they often find it very validating, actually. They'll go, oh my gosh, that's me, right? And it's important when we teach this to say, there's nothing inherently wrong with being a Ferrari, with being an emotionally sensitive individual. Some people are just born that way. Problems often start to arise, though, because of the fit, right? So then we talk about the invalidating environment. So I think of the invalidating environment as trying to drive a Ferrari car on like a narrow city street, like in Europe or something, with lots of twists and turns. An invalidating environment has these three components. We call it indiscriminate rejection of communication of private experiences. So this would be telling an individual, an individual says, I'm really upset in this moment. I'm really angry, or I'm really anxious. And, oh, you're fine. Oh, you're not. You're not really that upset. It's not really that big of a deal, right? That kind of minimizing. Intermittent reinforcement of, so it's intermittent reinforcement of escalation of emotional displays from the individual. So what this means is, when the emotionally sensitive individual is in a dysregulated state, maybe expresses this distress, says, I'm really upset, I'm really angry, I need help with this. The environment will intermittently respond to that. And intermittent reinforcement is actually the most powerful form of reinforcement. If you think about a slot machine in a casino, that is an example of intermittent reinforcement. You sometimes receive a reward for pulling the lever on the slot machine. You sometimes do not. And actually, that intermittent level of reinforcement maintains behavior for longer and with greater intensity than even regular reinforcement, because you never know when you're going to get it. So if the environment, for example, responds to an escalated display of emotion, sometimes, oh, you're really upset. Oh my goodness, what's wrong? How can I help you? Oh, that's so hard. That's so difficult. And then other times ignores it or maybe even punishes, saying things like, you're being over dramatic, get over it. That escalated level of emotional display is going to continue for longer and with more intensity, right? Because the person never knows, oh, is this the time I'm going to get, a validating, helpful response? So that's actually an aspect of invalidation. That intermittent reinforcement is actually, we define that as invalidating. And the third component of invalidation, as we call it, oversimplifies the ease of problem solving. So this would be telling an individual that, a problem that's actually quite complex for them. For example, regulating strong emotion is actually simpler to solve than they're making it. So, if you just put your mind to it, if you just thought more positively, you wouldn't be so depressed. If you just didn't let things get to you so much, you didn't let other people's words affect you to that extent, well, then you wouldn't get so angry, right? So these three components of an invalidating environment transact. So this is a transactional model, meaning the two impact one another. The emotionally sensitive individual and the invalidating environment transact and impact one another such that they affect one another. I think of it as the perfect storm, right? If you had an emotionally sensitive individual in an environment that was always validating, always told them that they understood what they were feeling, never rejected their private experiences, that individual might not come out with so many problems. Or you have a person who things just slide off of them, things don't get to them that much. And then they're told to just get over things. Maybe it doesn't impact them that much. And we all know people maybe that are like this. But when we have this perfect storm, they actually reinforce one another. So it's easy to understand probably how the invalidating environment could increase a person's emotional sensitivity, right? Or their displays of emotion or their reactivity. But also, let's not forget, the emotionally sensitive individual also impacts the environment to sometimes make it more invalidating. Imagine a person who always does have a lot of high sensitivity and reactivity and a lot of escalated emotional displays. Imagine then how frustrated or burnt out the environment could get and resort to statements like, you're really being overdramatic. You're really overreacting right now. You really need to calm down. So you can see how these things kind of go both ways. So this is Linehan's theory of how individuals come to experience the difficulties that they have. And the treatment of DBT really, in some ways, tries to provide that corrective experience, right? Of providing validation in the therapy experience, providing the experience of acceptance before probably we move too much to change. Right? So if you can go back to this idea of why was change so difficult for a change-oriented treatments like CBT, so difficult for individuals like this to tolerate, it's because they probably experienced messages of change as being invalidating, right? Just fix this about yourself, do this differently. If they've had invalidation all their life, are sort of like, no, this isn't going to work for me. I'm being told again that there's something wrong with me. And so this component in DBT of validation and of acceptance is pretty key. Let me see. Sorry, I just want to scroll through and see. Okay, let me do this slide actually. Are we on assumptions about individuals with BPD? It's probably still scrolling. I'll give it a second to catch up. There's a little bit of a delay. Okay, so assumptions about individuals with BPD. I like to talk about this because it gives us it sort of gives us a clue into the mindset of how we as clinicians like to approach the treatment. We can imagine how easily we might get burnt out or begin to lose compassion or begin to lose this dialectical framework when we're working with people who do have very intense, severe, high-risk behaviors like suicide or self-harm. And so we try to hold these things in mind. Let's go into the treatment assuming these things about the people that we're working with. One, the patients are doing the best they can. It's often hard as therapists to hold that in our mind, when we're burnt out thinking, oh, people just don't want to get better, right? Or they're not trying as hard as they could. Or they could be working harder, at this. Then there's the other side of things. They are doing the best they can. Here's the dialectic. They also need to do better. They need to try harder, and they need to be more motivated to change. So there's another dialectic, right? How do we hold both of those things in our minds that when we go in and we work with our patients, acknowledging that they're actually doing the best they can, which is that acceptance side of things, while trying to hold in mind that they also need to do better and improve. So it's this constant balancing act. Let's also assume that patients want to improve, that they don't like being, miserable and suicidal and in pain. That goes to the fourth bullet point, right? The lives of suicidal borderline patients are unbearable the way they are currently being lived. So let's assume that, and let's assume that they want to improve and get better and not go to this place of thinking, oh, they like being sick, or they like being the patient, or they like this kind of suffering. Oh, sorry, I skipped one. Patients may not have caused or created all their problems, and they have to solve them anyway. I will never forget the time that I worked in residential treatment with a teenager who said, she had been through a sexual assault actually at her school, and then as a result had some aggressive behaviors that were caused her to actually be asked to leave the school and therefore go into residential treatment. And she used to say all the time, I'm here in residential treatment and I'm being treated like I'm a criminal, when in fact I'm a victim. I was victimized because I was assaulted, and that's the reason I had all these aggressive behaviors, and that's why I left, and that's why I'm in residential. And this stuck in my mind. So there's another dialectic. Perhaps she is both a victim and she has had some criminal behaviors, right? And this reminder, she may not have caused or created all of her problems. It wasn't her fault that she was assaulted or that she, that she had that experience. And the resulting problems that she had as a result of them, right? The dysregulation she had, the aggressive behaviors, all of that do become her responsibility to solve. And so it's a mindset as therapists as we go in, right? Remembering that compassionate part, that validating part, that accepting part, about the problems that perhaps were not created by patients, and also keeping that change focus. Okay, I'm also here to help you make a change. Patients must learn new behaviors in all relevant contexts. This means that you can't just learn what you're learning in therapy. You've got to go out in the world and practice it, not just in the therapy room or in the group room. Let's also assume patients cannot fail in therapy, right? Because if we go in with that mindset, it's going to just eliminate, I think, a lot of ineffective belief that, well, that person just, they failed. They didn't do good enough, or they didn't want to improve. Treatments can fail. DBT, while it has a lot of evidence supporting its efficacy, can fail. We don't have perfect treatments, that can prevent suicide 100% of the time. And therapists can also fail. This is one of the assumptions we have in our consultation teams, is that we are fallible. We can make mistakes in the application of the therapy. But why don't we just go in and assume that patients cannot fail? And that'll give us a way of approaching this treatment that doesn't blame the patient. Another assumption is that therapists treating borderline patients need support in the form of a consultation team. And I'm going to talk about that. Okay, so so let's talk about what DBT looks like and the different treatment modalities. So standard DBT was created actually for adults originally in the 90s by Marsha Linehan, and it was an adult-only model. It's since been adapted, and I'm going to talk a bit about that. But I want to talk to you about what standard outpatient DBT and the way that it was originally created looks like. It involves weekly individual therapy with an individual therapist. It involves skills training, which, if it's for adolescents, the way it was adapted, can take place with family members altogether. We call that a multi-family skills group. But skills training is a component in which the client is being taught the 4 modules or the 5 modules, in the case with adolescents, of the DBT skills. And the second half of our training is actually going to focus on those skills. But that skills training is typically administered in a group setting. There have been adaptations to have it be delivered individually, but that's more of a didactic component where clients are learning skills. And that's a separate, that's separate than individual therapy. I think a lot of times people sometimes have misconceptions of DBT where they think, we'll have clients come in and go, oh yeah, I did DBT. And it's because they had a group or they went through some of the skills training pieces, like in a hospital setting or something like that, but they never had that individual therapy component. Third aspect is off-hours telephone skills coaching, or these days more often, sometimes it's texting, depending on the therapist limits. With the teenagers, they sometimes like to text. So this is access to your individual therapist outside of the individual therapy time for the purposes of getting coaching on skills use. So a client is having difficulty. They want coaching in the moment for what skill to use to solve that in the moment problem. It is not therapy. It is not a check-in. It is not an extra, session. I mean, if you have an extra session, that's an extra session. But skills coaching has a very specific designation and use. And then the fourth component, in order for it to be standard DBT, is that the therapist must participate on a consultation team. And a consultation team is a meeting of DBT therapists who are carrying DBT cases on their caseload. And Linehan refers to it as therapy for the therapists. It's a time when therapists can come together and consult with one another on the goal being their effectiveness in applying DBT treatment to clients. So in that meeting, therapists put themselves on the agenda for help in the work that they do. So it's not like a typical rounds type meeting that where clients are going on the agenda or we're discussing this client. It's really therapists putting themselves on the agenda for help with their work or help with their burnout or help with applying the treatment in the most effective way. So for DBT to be considered DBT in its standard format, all of these 4 components must exist. Now, in recent years, there have been development of these adjunctive or supportive therapies, some of this we offer here at Boston Child Study Center, and in various residential settings and other settings, these are offered. DBT parent coaching, which is parent coaching with just parents. That's DBT informed with DBT principles. DBT parent skills training, where the parents are receiving skills training, usually in a group format, sometimes in an individual format, where they're getting taught the curriculum of the DBT skills similar to their children or their teens or their young adult children. DBT informed family therapy, and DBT skills integration groups are these were sort of developed as almost graduate level groups. Once people had sort of gotten the training in all of the skills in the didactic format, they moved to a more process-oriented group where they are discussing integrating skills into their lives rather than just learning, the acronyms of what the skills stand for and more than just the book knowledge of it. How are they applying it? And then exposure coaching could be an adjunctive therapy. We'll talk about some of the adaptations of DBT, but this can be some of the exposure work that some people are doing that complement their DBT work, for PTSD or anxiety. Exposure coaching is sort of an additional adjunctive supportive therapy where the exposure coach is conducting exposures with the client that supplement or support the individual therapy. Okay, so I'm going to skip these slides in the interest of time. Let me go quickly to adaptations of DBT. See, these are some of the, are we on that slide yet? Adaptations of DBT? Is it showing up? Okay. Is the title hard to read on those? Okay, you can see it. Okay. So DBT has been adapted now from its original conception in working with adults to apply to adolescents. Alec Miller and Jill Rathis have a text as well as a skills training manual that is for adolescents. DBT-C for children. Francesca Paraplechikova has done adaptations for younger children, younger than high school age. And then Dr. Alan Frazzetti has focused on DBT with couples, as well as families has been his area of specialty. I have some of the resources at the end with some of the books that have been written by some of these authors. It's been adapted to different levels of care in different settings, so not just on an outpatient basis, but to residential. The 3 East Continuum of Care at McLean Hospital in Boston, which is where I did my training, was the first residential program where it was intensive residential DBT, originally for girls. Now they've opened a boys program. A partial hospital level of care, which they also have there. It's been extended to IOP level of care, which we offer at Boston Child Study Center here in LA and in Boston, and as well as it's been adapted for a school curriculum. It's called DBT Steps A. Doctors James Mazza and Elizabeth Dexter Mazza have done, there's a workbook that adapts the DBT skills training curriculum for schools so that it can be taught in a school setting. And then also adapted for different diagnoses, substance abuse, eating disorders, PTSD. There's a protocol. Dr. Melanie Harned has developed DBT-PE, which is a prolonged exposure protocol for post-traumatic stress disorder, based on Edna Foa's original prolonged exposure model for anxiety. It has been adapted to fit into DBT treatment for the treatment of PTSD. So that's an additional adaptation of the treatment that's been developed in recent years. And then also new research showing that the application of skills only, so skills training only without individual therapy can actually be effective. There's a slide here where they've done some randomized control trials, for, say, eating disorders, where people who receive only the skills training can benefit from that, which previously, when the original treatment came out in standard format, there was no component analysis of, if someone only went to skills training, would they have any benefit? So it's freed up actually our ability to now offer, groups, while we do recommend that people have individual therapy along with it, but if somebody can only access skills group, that at least gives them, that does give them benefit. Let's see. Okay, I'm going to talk a bit now moving into how we treat, how we conceptualize treatment. So as I said before, at the core of DBT, it is a cognitive behavioral treatment. And so when we do this treatment, we ask our clients to determine what are their specific target behaviors that they want to work on in treatment, that they are committed to and are focusing on in treatment. And we divide these target behaviors into 4 categories. And it's a hierarchy. So in DBT, if there are any target 1 behaviors present, which are life-threatening and self-injurious behaviors, those must be addressed in treatment. We cannot get to target 3s, quality of life interfering behaviors. I don't know, you have conflict with your mom. We can't get to those kind of problem behaviors if there are life-threatening or self-injurious behaviors still on the table. If somebody is threatening or attempting suicide, on a weekly basis or on a monthly basis or on a regular basis, we as therapists cannot get to those lower level targets. And so we show actually this hierarchy to clients and ask them in order, do you have any life-threatening behaviors? Do you have any self-injurious behaviors? Are there therapy interfering behaviors present? So therapy interfering behaviors are any behaviors that interfere with the effectiveness or progress of therapy. So not coming to therapy is a therapy interfering behavior. Not completing homework assignments can be a therapy interfering behavior. in-session therapy interfering behaviors like not answering questions, avoiding certain topics, saying I don't know when really you do know, but really it's that you don't want to talk about it. There can be low-level therapy interfering behaviors, as well as therapist therapy interfering behaviors. So therapists can do things that get in the way of therapy being effective. And we have our consultation team to talk about that. Quality of life interfering behaviors are things that do not escalate to levels targets 1 or 2. Panic attacks, arguing, perhaps eating disordered behaviors that don't escalate to a target 1 level. Substance use behaviors could fall in here if they don't escalate to a target 1 level. I get this question a lot, well, what if somebody's using substances, and when they're under the influence, that's when they're attempting suicide. Well, then perhaps if there's a correlation there, yes, substance abuse perhaps needs to be escalated to a target 1 level. And then target 4s are DBT skills. We are aiming to increase skill level and decrease targets 1 through 3. And so the way we organize these treatment targets is through the use of a DBT diary card. So this is the organizing tool that all clients will use in DBT. Across the top, we have some examples that are listed there, but we have the clients right up at the top of their diary card. And this is an adolescent one because it says school on there. But you see where it says self-harm, suicidal, and we can personalize this to have more in boxes. But at the top, we are writing what are those designated target behaviors that have been selected for treatment. And that's something that the client and the therapist agree on. So in this case, this person's diary card, suicide and self-harm, perhaps are issues. And if they're not, you might have others. You might have, fighting with mom, or not completing diary card could be behaviors that you list at the top. And what the client is instructed to do is on a daily basis, they fill it out going across. Each day they are to track their urge for that target behavior on a scale of whatever you want. It says 0 to 5 here, but you can modify that. And then their actions, yes or no, did they act on that urge? And then they complete, in this case, the person had, risky sex is one of the behaviors that was an other behavior for this particular person. Meds, were they taken as prescribed? School could be an issue. Missing school could be a target behavior. And then on the right-hand side, they're tracking their emotions, their emotion level. What was the highest that it hit on that day? And then any notes. So you can imagine at the end of the week, we have a lot of data. The client brings us to therapy. The therapist reviews this, and we have a picture basically of the entire week of how that person's week went, what they were experiencing, and how their target behaviors were that week. The bottom has a list of all the DBT skills. Well, actually not all of them, a majority of the DBT skills, and the client is asked to circle and track when and if they used any of those skills. So the therapist's task, and this is really a nice structure to the session. When the client comes into session, they are handing over one of these diary cards. If it's not completed, that is a therapy interfering behavior. You might ask the client to complete it in session, right, sitting there with you. And you're going to scan according to this hierarchy. Do you see any target 1 life-threatening behaviors or self-injurious behaviors that have occurred? Are there any yeses on this diary card? If so, you've got to address it. You're going down each level, right? If there are no target 1s, go to target 2s. If none of those, target 3s. And so it really organizes what you're dealing with. And it's very helpful to the therapist, especially when you're getting multi-problem clients. They're coming in with, oh, I had this crisis, and then my friend, won't talk to me, and then, oh, I also self-harmed, and then, I got in a fight with my mom. It really helps you organize, okay, well, the self-harm is what we need to talk about first. And what you're going to do, let me see if I can change. I want to show you the tool that we use. If there are any problem behaviors that occur, you're going to be conducting a behavioral chain analysis of that behavior. And I'm going to show you what that looks like. How do I change my screen? Let's see. Oops. Are you seeing this? Okay.
It's on application.
Let me change to, oops, how do I go back to this? This one? Oh, this one. Oops. Sorry, that's not the one. Let me do entire screen. It might be easier. It's the eternal. Here it is. Okay. Can you see this? Behavior chain analysis of a problem behavior. Sorry, there's a little bit of a delay. There we go. Okay. So when a problem behavior shows up on the diary card, this is just an example in my previous practice that we use. The client is asked to go through and essentially analyze all the links that led to that behavior. And this is sort of the conception we use. We conceptualize behavior as being these links in a chain. And these links can be feelings, events, actions, sensations, or thoughts, right? And all of these things create a chain that lead up to eventually, I self-harmed, right? And so if we can break apart each of these links and we can analyze this and we can understand it, the idea is then we can solve the problem. We can break this chain. Okay, so this is a long, I mean, it's a pretty long form, but it, it asks for what happens afterwards. So we're assessing for the consequences that occurred after the behavior. Was there anything reinforcing the behavior? Maybe after I self-harmed, oh, I felt a lot of relief. I wasn't angry anymore. Oh, that gives us some information then about why that behavior is continuing. It asks for ways of how to practice more skillful behaviors and how to perhaps do a repair or an overcorrection if your behavior caused any harm. And there are many, many different formats of this behavior chain analysis, but I wanted you to see conceptually what it is that we're asking a client to do. And this is very much a part, it's very much part of CBT, of a behavioral analysis, a cognitive analysis of what thoughts were you thinking. And it's a way of breaking down and really trying to figure out what led to that problem behavior so that we can go back and perhaps find more skillful ways. Okay, let me get back to my slides. Okay, so I hope that makes sense that, you're looking through this diary card. Oh, something's popped up here. You had a self-harm action. Okay, let's go do a chain analysis. Oh, nothing there. Okay, we can move down to quality of life behaviors. Okay, oh, you got in an argument with somebody. You said something insulting to someone. Oh, that's a target behavior. Okay, let's talk about that. We can even do a chain analysis with that. And oftentimes you don't have to go through that whole long form. Sometimes once somebody, maybe for the first few times or for very high level target one behaviors, you want to use that form in its entirety. Sometimes it's a little mini chain where it's verbal and you're discussing it. Okay, take me through what happened. Take me through the links. What were you thinking? What were you feeling? Did you have body sensations? Okay. Sorry, I'm looking at what I have here. Okay. Are you on the slide that says DBT interventions, balancing acceptance and change? Okay. This is an overview, of course, in a 2-hour session. We don't have time to go over all of the different interventions and strategies that we use in DBT, but this slide is a summary sort of all the different strategies and interventions that we use. And so Linehan categorizes, acceptance strategies focus on emotional, behavioral, and cognitive validation. And I'm going to talk a little bit about levels of validation because that's one of the key strategies that we use in this treatment. And then a bunch of change strategies that balance the other side of it. Commitment strategies, which are strategies that you use to get a client committed to treatment initially. The diary card is one of them, as we just reviewed. Didactic strategies are ones in which you're teaching, a little bit like psychoed, right? Orienting and micro-orienting. This is where you're continuously orienting the client throughout treatment to the rationale behind why we're doing something. For example, a behavior chain analysis, why do we have to go through this big long thing? Oh, remember what your goal was to, eliminate self-harm. This is the tool that's going to help us with that, because it's going to help us understand what's leading you to that. Solution analysis is similar to a problem behavior analysis, but it's the opposite. It's looking at the steps that led up to a effective behavior. Oh, you actually managed this time. You avoided self-harming. Let's take a look at all the steps that led you up to that. Contingency management is basic behaviorism, managing things in the environment that might be reinforcing problematic behavior. Sometimes this involves creating behavior plans if it's with children or adolescents. How do we manage what's happening in the environment such that ineffective behaviors are not being rewarded or reinforced? For example, somebody self-harms and comes and shows a parent. We don't want that parent reinforcing that with extra support, extra caring, extra warmth. That then reinforces that behavior. Oh, when I self-harm, I get a lot of extra care and support from people. So contingency management is a bit of that, working with the environment at times to try to manage that. Exposure procedures are about, exposing clients to emotions that they maybe have difficulty experiencing or that they're avoiding, or situations that they're avoiding. Certainly in the PTSD DBT PE protocol, the prolonged exposure protocol, a lot of exposure procedures involved. And then skills training is the component that we're going to focus on in the second half. Dialectical strategies, these are, I'm not going to go into each one of these, but these are strategies the therapist uses to maintain that kind of dialectical stance. A bit like when I pose that question of, can you stand in the same river twice? Oh, yes and no. What's that like, to kind of sit with two different sides of things? And then stylistic strategies are about how the therapist stylistically approaches sessions. We talk about reciprocal versus irreverent communication. Reciprocal communication is communication that is warm and validating often, and can often be used as reinforcing. When the client is being effective, when they're working, when they're completing their homework, when they're calling you for skills coaching before engaging in a behavior, giving that warm reciprocal communication. Versus irreverent communication is used, in different situations when a client is very stuck, when they are, they're in a stuck place and you need to say something that shakes things up a little bit. We might use irreverent communication. I had a client in this morning that was laying on my floor and didn't want to go over the behavior plan that her parents had developed for her. That I had helped them with, and she's laying on the floor and I said, oh my God, but I worked so hard on this, and you're just going to roll around on my floor. So a little bit of irreverent communication to try to shake the person up. So let's focus on the acceptance strategies. Levels of validation. I can't overemphasize how important these concepts are of validation. Recall what we talked about biosocial theory and how much invalidation impacts emotionally sensitive individuals. And, ultimately, the goal really is to have clients be able to self-validate, right? To be able to give themselves validation. However, if they've never experienced this for themselves, validation from the environment as sort of modeling is very, very important. So we'll practice this as therapists. We do this, and then we also teach this to, family members, so that they can get more skilled at doing this and giving the client an opportunity to experience validation so they know what it is. So Lenahan has a wonderful article on this. It's called Validation in Psychotherapy. It's actually at the end of the slides. If you all are interested in learning more about levels of validation, that article is wonderful. But this is a summary of it. There are essentially 6 levels of validation. And obviously, as you know, those of us out there who are listening who are clinicians, we obviously learn a lot of these in our, just in our sort of basic clinical skills. But level 1 is staying awake to the person's experience, listening and observing. I work with a lot of teenagers and kids who say, this is all I want from my parents. I just want a level 1 validation. I want them to stop talking, and I just want them to listen. I don't want them to solve my problem. I don't want them to tell me how I can make the situation better. I just want them to listen and observe and be awake to my experience. Level 2 is accurate reflection, the ability to actually say back to a person what it is that you heard them say, what it is that you heard them say about their experience. So someone comes in and says, oh my gosh, I was stuck in traffic getting here to your office, and then I couldn't find parking, and then, oh my God, I'm like so flustered. For you to say back directly, oh, you you are so flustered, and you were stuck in traffic, and you had a hard time finding parking. And sometimes seems a little like, yes, that's what I just said, like you're parenting back a little bit, but it can also be a very powerful form of reflection, a form of validation, to just be able to reflect back exactly what the client has said. I've heard this, I've seen this be extremely powerful in amongst families sometimes, having parents repeat back to the child what it is that they heard them say, or the teenager. It sometimes might be the very first time that they actually heard their words reflected back, and be like, oh my goodness, you really were listening to me. Level 3 validation is articulating the unverbalized. So this means, or reading between the lines, this would be saying something that maybe the person didn't actually say themselves. So, maybe the person didn't say that they were really flustered when they got to my office, but I was able to listen to what they said and then come back and actually articulate what they didn't say. Oh, you couldn't find parking, and you were stuck in traffic. You must be really flustered and sort of, all over the place right now. So articulating something that they didn't say can be a very powerful form of validation, and that the recipient feels in some ways known. You sometimes have to take care with this. For people that are sensitive to invalidation, you want to make sure that you're not maybe assuming things. You can sometimes get no, that's not what I'm feeling. No, you don't get it at all. And so sometimes doing this in the form of a question, or saying, oh, I imagine, or I imagine you must be really flustered, or am I getting this right? Were you really anxious when that happened? So a little bit of a tentative approach to this can sometimes be helpful. So I'm just going to take a drink of water, talking continuously. A level 4 validation is validating in the context of causes or of a person's past. So I sometimes think of history, pathology, biology. So this is saying that somebody's behavior or experience makes sense in the context of their past history. So to do this one, you do have to sort of know a little bit about a person in order to be able to do this one. So it could be something like, oh, of course, when you walked into that party that was filled with a bunch of strangers you never met before, that you were super anxious, given that you have social anxiety, that's something you struggled with in the past. Or yeah, when that coworker of yours made a comment again about the work that you did, of course you got so frustrated because that coworker has been criticizing your work for the past 6 months. Something that is rooted in a past experience is a level 4 validation. Again, some people find this extremely validating, especially when it takes you knowing a little bit about a person before you can do a level 4. but they find it extremely validating in the sense that, oh, you actually know me. You know a little bit about my past, and you're linking it to my present experience in such a way that I feel very understood and I feel very known. A level 5 validation is validating someone in saying that their present experience that their experience makes sense in the context of the present moment or present circumstances. This one is a little bit like normalizing behavior. You know, anybody who got stuck in traffic would be flustered. You know, it makes sense that XYZ happened, and so therefore you're feeling that. You know, it makes sense that when your boss gave you a bad review, you know, a bad performance review, that you felt extremely disappointed and, you know, sort of down on yourself. So it doesn't necessarily have to involve any context from the past, but just something that just is in the present moment. This makes sense. And maybe anybody would feel that. And a level 6 validation, you know, this is something that we try to bring sort of to all of our work, right? We call radical genuineness. I think of this as, you know, treating the person as a whole as valid, treating them with sort of a genuine, empathic approach. You know, oh my God, I can't believe that happened to you, or oh, that's terrible. You know, I feel sad listening to you talk to me about this. So a real kind of radical genuineness in the way that you approach your validation with the person. I'm going to take a 2-minute break before we move into DBT skills training. The second part of this training is going to focus on these particular skills. If some of you haven't had experience with doing DBT and individual therapy before, some of your initial exposure might be in skills training or participating in a group or doing skills training individually with somebody. And so I did want to make a focus of this training to be on the skills training and some of the actual skills I wanted to teach so that you can get some exposure to it. I'm going to take a little 2-minute break and we'll be back.